Okay, she looks beautiful. She really has great skin and everything. She's got beautiful cheekbones. I thought, we would try to fill in some of the gaps. If you take a look, do we have a hairband that we can use on her?
I do. Notice he's doing exactly what we were talking about is point out the positive features. Most patients have lots of positive features. She's got lots of positive things. Those cheekbones are to die for. So you can thank her parents for that. So she should be...
Sure. Can we get the lights down and I'll just work off this... Or maybe I won't.
Where did this come from?
Right there.
Good.
Fine. Yeah.
Hey, that's great. You wear your hair up, down? What do you do?
Usually bangs.
Usually bangs? Mm-hmm. Kent, do you want to comment on the fact that, we are using HAs. HAs are water absorbing and water binding, and you find that on the post pictures, even immediately post picture, that the patient has more reflection?
Yes.
That they have a little more water content into their skin?
Well, this is why there's a big interest, again, in using the little tiny droplets, either roller techniques or little needle puncher techniques of getting hyaluronic acid in the subdermal area because it attracts water, increases radiance, increases reflectivity, gives you more youthful reflected light. So there's something about doing, even when we're doing these candidates we're talking about with the group down here, for these fixed creases and lines on the face, and you blend it a little bit, even 1 to a quarter or 1 to a half or 1 to 1 mix, whatever you choose, and you do a spokes on the wheel pattern through the whole face and do subdermal, they look much better in a few weeks because of reflected light and radiance, but they even look better in 6 to 8 weeks because of stimulation of collagen. And if you're using a little meso mix, sometimes it'll shrink the basis units because the basis units are activated the same way as eccrine units by interfering with the cholinergic, the preganglionic interference with the cholinergic system. So
I'm going to try to fill in some of the gaps, and she gave me carte blanche. Do whatever you want. Great. We're going to do a breast augmentation. We're going to do a tummy tuck. Okay. So here we go. Forehead. I'm feeling for the temporal crest. I'm going to mark out the temporal crest. Like I say, I do this even in my office with pencils, just to make sure that I know my landmarks over here. Look at her forehead. Increased convexity. I'm going to turn your head. You can turn your body a bit so they can see. Look. Increased convexity of the upper forehead. That little suprapromontory defect. And then a little bit of heaviness of the brow over here. So in her situation, I can see already that she has this area over here. Okay. That can use a little bit of filler to try to give her a nice smooth contour. Can you raise your eyebrows for me? Good. Okay. Relax now. Let's take a look. So I'm going to mark out, people ask me about how far apart. I usually do it about 1 centimeter apart if I'm using a needle. So she's going to have 5 or 6 little places over here. 1, 2, 3, 4, 5, 6. Lucky 7. I have already pre-mixed from the first case, but not on a patient's needle that I used. I have a little bit of Resti. That's blended 50-50. I could use silk over here. Give me a cleanser, please, and a pad. I'm going to dab the area and leave those areas here circled so you can see what we're going to do. And I'm going to show you the technique of using this small little thing with a very floppy... This will eventually come down, I hope. If not, it's just going to look bad on the video, but that's all right. I'll turn her head a little bit. If I can get the camera to focus from here to here, please. Really feel like a director with that boom, huh? Mm. Tell Mr. Cruz we're ready for him now. Okay, so here we go. My injection is going to be vertical. It's going to be down on bone. You're going to feel a small little stick, and I'm right down on bone right now. Look how much of my small little needle is still sticking out. I told you the depth here is no more than 2.4 millimeters. I'm going to start a slow amount of product to start. I'm watching the skin. When you inject, you don't watch the syringe. When you drive, you don't look at the steering wheel. You look at the road. I'm watching the skin to see what happens with the skin. It's going to bump up ever so slightly. I'm going to remove my needle, and I'm going to press it flat. That is the whole thing that I do when it comes to doing foreheads. Period. Okay? I might have gone through a little blood vessel or something, so I'm prepared with my compress. We're going to do the same thing over here. Small little injection, right down on bone. Little injection. Again, it's not a lot. Look at the way it's bumping up after 0.025. That's perfect. And then just lay it down. One more time right about over here. I could be right through supraorbital or supratrochlear. I can't tell. I'm ready for it if I do get it. And so far we're being pretty lucky. I'm missing everything. But it is pure luck. But I know that if I inject onto the periosteum, I'm behind the galea and I'm behind the vessels. And that's how I do it. There can be...
The other nice thing about these fixed needles that are fused onto these little minis is if you look at the bevel of the needle, there's hardly any bevel at all. So that's an advantage too for trying not to get into a vessel, because it's such a short little bevel. When you're on top bone, it's usually not a challenge.
Now you tell patients when you do this technique that there can be some waviness to it. Okay, you can see a little bit of it. If you find that it's a little bit too much, you can sort of go on the in-between areas and put in a little bit of product if you have to. But most of the time, not all the time, all the time, this will settle down by itself. And the cool thing about it, and I hope it's going to work, and we're going to see. If it doesn't, it doesn't. No, what I want you to see is the fact that on this side now, and maybe I'll try to do the other side with cannula, or maybe I won't do that with her, but we'll see in a second here, is that, raise your eyebrows again? They both move perfectly well. Okay? So the lidocaine hasn't affected the frontalis muscle. Okay? And even if you look at the contour or the quality, you see what I do? I erase the circles as I go across. This is a cool thing to do in your practice, because very often a nurse will pop open the door and say, oh, patient so-and-so wants to know this or that. You get distracted. You forget where you injected last. Where I haven't injected is where the circles are remaining. So I erase as I go along. Okay, but I'm going to show you here. We're going to erase this anyways, so you can get an idea of what the contour has done. Can I have a little bit of the ultrasound gel, please? That's looking pretty good. She has sensitive skin. She's a little hyperesthetic and turns a little bit pink.
So on lips, you want to just blend. Here you want to almost massage a little bit. At least I do. It's more of a massaging.
Too. Yes.
And molding a little bit more assertively than you would lips or noses.
Okay. So, the idea is you see the contour now on this side, and you look at the contour on the back side over here, and she's missing still a bit over here. Now, she wasn't a very intense case, but she was just, showing for demonstration purposes how I would do it. Typical volume is about 0.025. You watch the skin. Don't look at how much you're injecting. Watch the skin and see what the skin does. If it starts to bubble up, you just go ahead and you stop over there. Okay. Could I have a dry sponge, please? And we'll take a look at that again in about 10 minutes and see how it's going to flatten out. Once it picks up her body heat, it's going to sort of spread on its own. And I can tell you guys can't see it, but I can tell you that I can see some lines that are coming across over here, and they're just wiped out over here right now. Why that is, I don't know. I think it's what I call the chair effect. She has a little support there. The muscle relaxes just a teeny little bit and effaces those lines. Great combination therapy to do filler down here and toxin higher up. Okay. What else did I want to tell you about the forehead? Was there anything else? I had something else on my mind, but I can't remember.
How deep do you do your Botox neuromodulator on the high forehead? What's your depth?
There was a study that came out that showed intradermal is just as good as intramuscular over there. And I think if you go intramuscular, I told you the vessels are sitting on the muscle so that you have a chance of bruising the patient. So I just do all my injections intradermal. What do you do? I do too. Okay.
Yeah. How about if the lines were just above the brow?
So let's say she has this, what she does. She's had toxin, obviously, in her forehead, and you can see that she is one of those cases that she's almost pulling at the level of the temporal crest line. Can you lift up a bit? I have a beautiful video of a woman that we had done in the study where we were doing injections and numbing out the frontalis, and then she pulled over here. So she had a couple of fibers there. What do you do for this? What would you do? Inject it with a cannula. At what depth? You can't get into the dermis properly with a cannula. So you're telling me to inject her subdermally over here with the cannula? Is that right? That's a good response. I mean, I might try that. I do sometimes intradermal injections with a small BD2 just to give them a little support. But if I am going to use toxin over here, this muscle is hypersensitive now to any toxin. It's almost the same thing as a patient who's had paralysis on one side of their face. We use microdoses on the opposite side because their muscles are so sensitive. She's hypersensitive here. If you drop in 2 units over here, you're going to hear her brow hit the ground. So what I do is I have them raise their eyebrow up. I find the highest crease point, which is right about over here, and just above that, 1 millimeter or 2, I put an intradermal half a unit of toxin because I'm trying to moderate and not obliterate those lines, and it'll soften it just a bit. If that doesn't work, then I will go with a cannula or with a fill like you were talking about. That's my personal way of doing it. Ken?
I use 1 to 2 units of Botox, generally 1 unit.
Yeah, 1 unit's fine too.
Just right at the peak.
chicken. So that's basically how we do forehead. You can see the nice contour that she has over here, and you can see she has even a smoother, more reflective surface here, and she's doing very, very nicely. Great. I'm going to do temple now, unless there's any questions about that. And the reason that I'm going to do temple is to see, let me take a look at her as we sit her up. Okay, she has about symmetry in her eyebrows right now, but I'm going to cause a little bit of asymmetry. We're going to mark out, you're good? Mm-hmm. Great. Can I have the marking pencil again, please? We're going to mark out the temporal crest line. Okay, here it is. That's the temporal crest. I can feel it. This is her orbital rim. I'm looking to go 1 up, 1 over, and guess what? She's got a vessel that's right in the way, right over there. Can you see it? Yeah, you can. It's a nice big one. So my goal would be to put it somewhere over here. That vessel is probably a vein. I could go through it, but I don't want to cause a bruise or anything. I'm going to take, what do you have? Yeah, how about, let's see, on her, I don't need really much. Oh, maybe, she has kind of, if you take a look at her temporal fossa, she's a little bit sort of, it's almost a shallow dish. You know, it's one of those dishes that are like this, like a satellite dish, rather than a real scoop and a parabolic thing. So I want something that's going to spread pretty quick. Go down there. I could use wetted down Voluma, but we've used that product. Let me showcase another product. Why don't you give me just plain Resti? I'll use Restylane, not even Restylane Lift. I want the product to come up, which it will want to do. It's going to hit its head on the deep temporal fascia, which is on the surface of the muscle, and then it's going to spread along it.
You want a mini?
I could use it in a mini, or I can use it just straight up with the needle. Give it to me on a 30 gauge half-inch needle, please, and I'll take a little cleanser.
Why don't you use that Terumo needle?
Oh yeah, that would be cool too.
Use the red Terumo.
The red Terumo also works very well. That's a 29 gauge. It's also very good. I'll take a little cleanser on this, please, guys, and a dry one. So a little bit of a challenge because the vessel's in the way. I'll tell you a story while I'm waiting for it. I did this in Australia about 7 or 8 years ago when I was showing the 1 up, 1 over technique. I think it was about 7 years ago. Everything goes so quick. And then one of the reps came over to me as I left afterwards, and I showed this technique, and she said, "Can you do my temples?" And I had already walked downstairs to get my computer bag, which was in a small room with one single light bulb on there. And I said, you know, there was a trail of doctors that were following and asking questions. We were about 10 or 15 of us in a small little room. And she said, "Can you please do my temples? I've always wanted to get it done. And you said, you know, it's fairly safe if you go down on there." And I was always afraid. And I saw your results and I want to do it. And I said, you know, I don't have any product. So, of course, she reaches into her pocket and says, "I do." I said, "Yeah, but I don't have much light over here." She says, "But you said it's really a safe technique, that as long as you're on bone, you're pretty safe." And, you know, I had 20 doctors over there that were saying, yeah, do it. Am I stupid enough to inject a person like that in suboptimal conditions? Thank you. So you know me. There wasn't even a place for us to sit. So they brought in a chair, and this is the truth. I sat on the chair, she sat on my lap. She was side saddle on my lap. I held my hand around her like this. I felt 1 up, 1 over. I fired my needle in. I went down to bone. I started to fill. I was pushing over here to make sure. I have my finger on her pulse now. I had my compress on her shoulder waiting for it. I took out the needle to get my compress, and she ruined my best tie. I went right through that artery, and it splurted me right on the tie over here. It came flying out. That 20 doctors went, I said, "Don't worry about it." I had no assistant or anything. I said, "Patient always has 2 hands. You might as well involve her in the treatment." I said, "Hold this over here. I'm going to go do the other side." And I went and did the other side. Didn't hit the artery there. And she held pressure. She held pressure for about 3 minutes. When you're using a 29 or 30 gauge needle, it takes about 1 minute and 30 seconds for everything to seal, if they're not on blood thinners, which a lot of them they throw at you. But that was it. She didn't have a bruise that day. Didn't have a bruise the next day. Didn't have a bruise the next day. And she looked perfectly fine. So you don't have to be afraid of that. As long as the needle is inside the vessel, there's a tamponade effect if you're through it. It's only when you remove the needle that they start to bleed. I'm going to talk through this now as I'm explaining to you. I'd like to avoid that little vessel. So I'm going to go perhaps, let me see. I'm very close. She's right where I want it to go. I'm going to go just behind it, okay? I'm going to give her a little flick. And you can see that my needle is now down pretty much almost buried to the hub because I went a little deeper. I'm putting my finger behind over here. And I'm going to start the flow of product. I told you the flow of product is going to go in all directions. But I'm not going to let it flow up behind my finger because I want it to come down where my pinky finger is here. It's a slow injection. I'm watching the skin constantly to make sure there's nothing happening over there. I can see it bubbling up here. You can see it starting to fill over here, and it's going to start to come down. Okay, I'm going to put in, let's say on her case, maybe 0.0405 because she has a fairly broad temporal sort of hollowing. I'm not moving my needle, and in fact, every time I do this injection, I must change my needle because I'm pressing against the bone. Gently, but pressing against the bone. I'm now going to remove my needle, and I have my little pad over here. I miss the vessel, but even though I don't see any blood, you can change that needle, please. Even though I don't see any blood, I hold pressure. Why? Because there's a vein in the area called the sentinel vein. It's a vein that we look for when we do forehead lifts and brow lifts and we do face lifts. That right next to it is the branch of the facial nerve. That's the frontal branch. Had I touched her facial nerve, which I've never seen happen because it's already arborized and small in that area, you would have seen her eyebrow flick. It would have just flicked like this, in which case she would have said, I felt something, so you pull your needle out. You just don't inject. But I might have gone through that deep vein, and she won't bleed on the surface here. When will she show that bruise? 2 days later. And it's a yellowish green, and that's a tough color to cover with camouflage makeup. And they'll come in and they'll say, I'm having trouble with this over here. So I get the patient, I'm talking, so I'm doing this, but I'll get the patient to hold it, or my nurse, if she's in the room, to hold it. Even if I don't see any blood, put pressure on that area, and then walk over to the other side.
What we often do, because we do lots of this as well, is like you guys, is just have them do a Valsalva, bend right over with her head between her knees while you're talking a little bit, and then back up and mark those veins that are standing out. It's just easier to mark them, especially if your light's not good. Then you can see every little tiny vein and just go between them. But you can stop it. You can stop a garden hose with pressure. So even a vessel that spurts like that, you just put a little pressure on it and carry on because it'll just stop.
Okay, so the question was, why did I use the product? Blended. It was pure.
You're going to predict that she may get some more fullness in the future?
But the swelling, no. Interestingly enough, they can swell a little bit, but if you've ever seen the deep temporal fascia, which is lying on the muscle, I don't understand how this balloons out at all. I was talking to my friend Val Ambrose about that. He said, there's no way you can balloon out that fascia. We go underneath that fascia when we try to lift broken cheekbones, and we cantilever off it. And you can't even get through it with a Gillies, which is, one of those forceps or things that we use for that, one of the snaps that we use. So I don't expect her to swell that much. I do expect that vessel that I was next to is going to be perhaps a little bit more prominent. Okay? But I don't really see a lot of swelling there. And I chose that product for 2 reasons. I wanted a product that spread a little more. Okay? It's not as cohesive as the Ultraline, for example. In this case, I used the Restylane because I wanted it to spread along the whole dish. It's like having that bowl of cereal in the morning with a flat dish instead of a deep dish. And the second thing is because she's 60 plus, which I refuse to believe, she's BSing us, but anyways, because she's 60 plus, her skin is thinner. That's why I'm seeing that vein. And I want a product that's softer when it lifts. I don't want to cause a tent pole effect underneath. So we held some pressure here. I'm curious to see what happens with her eyebrow. Open her eyes. Okay, that's fine. Don't have to pull it up so much. And we'll take a look. Turn over here. You can see a little bit more of the prominence of the vessel, but she is flat. Okay?
About how much product was that?
That was 0.4, which is... What else would you like to use? I could use Ultra over there. I don't think Ultra Plus would have been great. I could have used Voluma wetted down. I could have used Ultra wetted down. I could have used Belotero Balance. It might have been a little too soft. I probably, if she was a little bit more mature and had thinner skin, I would use Belotero Balance. If she had a defect that was left over here, Let's look you right into the camera there. That's it. Okay, beautiful. If she had a defect that was left over here, I could come back in with the cannula and coat it, but she's filled all the way down to here now.
Yeah.
Okay? And you can see that. She's got a little bit of a...
Curling iron burn.
Is that a curling iron burn?
Yeah, it's classic.
It's classic, huh? Not used to your big cheekbones, are you? Uh-huh. Got to go sideways through doors a little bit? You find that? No, okay.
For a really, really narrow temple, would you use Ultra Flush?
Yes. Narrow temple meaning it was more like this?
Super hollow, yeah.
Yes, that would be a great product to use there. I could use Ultra Plus. I could use the Voluma, which will stay together closer together. I could use, if you want, Restylane or Perlane even, which is Resty Lift.
Sculpture there?
Yeah, I used to do a lot of sculpture over there, and I used to do a lot of sculpture all over the face. I personally don't do that much anymore. Becky Fitzgerald is great at it. I'm just a control freak. I don't like to inject something. That's just me. I just don't like to inject something that I'm at the mercy of the product and how it responds afterwards. So once they came up with more robust HAs, I started using those instead of the Sculptra. But for example, until we figured out how to do the cross-hatching and the technique that Ken showed over here, Sculptra was the answer for me for submalar hollows because of the fact that I had no support underneath and I was trying to thicken the skin. But I can do that with filler now, and I love having an eraser. That's just me personally, but I think Sculptra is a great product. I used Radiesse when I just did a study recently on jawline by putting in a deposit over here on the jaw. Okay, a deposit in the pre-jowl, a deposit. Look at that beautiful gonal angle she has over there. There's not even a parotid. There's not a parotid cell anywhere in the area. So I would put one bolus here of Radiesse, and then run an I-bar across it. Its G prime is somewhere up around 1500. So it's, and sometimes I think 2500 when you don't add in the lidocaine, but you always add in a little bit of lidocaine to bring it a little more comfort level. And that is really good in patients who have very thick skin and you really want to define it. I think it would be a little bit too thick of a product in her. But it's also a great product, and I used to use it for a lot for marionettes because it was robust and it would brace across the marionette. So, what else did we say we were going to do on you?
Collapsed
valves. The nose. When you breathe in, let me take a look. Wow. Do you see that? Do that again. Oh, this is a challenge.
And she's had a rhinoplasty too.
Yeah.
It was, well, they broke it surgically to take out a brain tumor.
Right.
Oh, so we're working with that? There might be a connection between here and here. Let's fill your brain with filler. Why not? Okay. So here we go.
A neck lift here?
No. I've not had any.
So what's this?
So they went in transphonoidally to take out a tumor that you had in your pituitary. Is that what the story was? It was a pituitary tumor? Okay, that's usually the story, but that means there's a communication over there. Let's be a little bit careful with this. That'll be fun. Okay, so she's a little bit broad-based on the top over here if we take a look at her nose. Right? I like this side now. For some reason, it looks just a little bit better. But anyways, she's a little bit broad-based over here. I'm going to see if I can go ahead and make her look a little bit narrower and also give her some support for that collapse that she has. So this is going to be a challenge, but we're going to take a look and see if we can do it. First thing I'm going to do...
Also commented on her columella.
Yeah, which is a little bit, absolutely. We like to see about 2 or 3 millimeters of columellar show. To me, she's showing too much of the inside of her nose there. I don't want to see nasal hairs on women. I'm going to adjust that too, and we're going to see at the same time. What do you think about her angle over there?
I think it's actually pretty good.
It's pretty good. She doesn't have a perfect genu. She's a little bit. Genu is the knee bend that we talk about over here that we try to create during surgery. And she's pretty flat on the dorsum, but to me her nose looks a little bit short for her. So what we're going to do is the following. We're going to take our marking pen.
You want to measure her nose there out of curiosity with your caliper?
You put the patient, you sit them up, you have them look straight ahead. You get the lash line, which is up over here on her, and you do that. Okay, you try to draw it. Maybe that's a little lower. We'll take it a little bit higher because you're looking up a little bit. Let's get you to look this way. Okay, let me have my caliper. We're going to measure over here. She's quite telecanthic. She's quite wide over here. And we're going to see that, yes, turn sideways, that her nose is about where it should be if it was here, if it was starting there. But when I look at her, her nose starts here, a little lower. Hard for you guys to see maybe, but I'm turning. There you go. You see the way she's still scooping at the top over here where my line is? I think she would look better if we added just a little bit of volume over here. So we're going to do that. I want a product.
The glabella meets the radix is what you want to do.
No, I'm going to use a product that I want to stay very tight together because I'm trying to narrow her bridge. I don't want it to spread over the top of the bridge. So I'm either going to use Resty Lift or I'm going to use Ultra Plus, which is what I can use as well, whichever one we haven't used it. Okay, we haven't used Ultra Plus yet. Let's use that. I'm trying to give every company its due. But you can use either. And I want you to load it into a BD2 backwards.
0.3.
Yep. 0.3 one, because I'll never get it through anything else. So we're going to take this off. I'm going to show you, this is how I do noses in my practice. This is the one that gives you the best markup on what you do. And you don't charge for the product here, God forbid. Why would you do that? You're charging for the experience in the hand. So watch what happens now as you fill with this little 27 gauge needle that comes with the product. You put it in backwards like this. Can you focus in a little bit more on this syringe? This one right over here, the small one. Beautiful. That's great. I'll turn it a bit so you can get a view of what's happening. Okay, here we go. Let's walk it down. I'm going to start the flow of product. Watch what happens, what Kent was showing you before. You see the product? Now which way is the flow going? Backwards.
Proximal.
Yeah, it's coming back because look at the size of the needle. It's all a question of resistance. It's coming backwards, backwards, backwards. When it's almost ready to touch the hub, I remove it. Then I take the plunger that's been held sterile, and as you introduce the plunger, watch what happens. The air precedes it and goes out. And now you have usually, I did it really well. I have 0.2 in this case, which is great. That's a perfect amount. Where are my injections going to be, guys? Off midline or midline? Superficial or deep? We're wasting our time here even sharing with you guys. Absolutely. Can I have a dry sponge? I'm going to turn her head so you can get a view of this. You're going to bring the camera into about this thing so we can really see how I batter and bruise her. You're going to feel a small little stick. I'm going to balance myself over here. I'm starting just below the level of where I think her nose should begin. I'm going to force the skin up at the same time that I put the needle in, and I must feel bone. I'm on bone right now very gently. I'm going to start to inject very slowly, and look at where I'm keeping my fingers. Like
holding it so it doesn't spread, doesn't splay and spread laterally.
That's exactly what I'm doing. And slow, slow, slow injection, release. You know, the radix area is a curved structure. It's not straight like an avatar. So what you want to do is you want to create that curve. This is your Da Vinci signature, is the pulp on your finger and your index. Your index and your thumb is by pressing over here, I'm creating that curve. Okay? And then you just hold a little bit of pressure over here and we'll continue down the nose. Okay? We're going to do a little bit over here like that. Right down on the base of the nose again. I have to be touching bone to inject to be in the safer area. Small amount. Release. Tap. Okay, I want to show you what's happening so far. You can now see that the root of the nose is now up here. But look, I still have, you see how I raised the root of the nose, that she still has a little depression right here where my needle is showing? So we're going to do that area right now too. And what I'm trying to do is create, small little stick, I'm trying to create a light reflex.
So are you at the rhinion there?
Yep.
Junction of the bone and the cartilage.
Sometimes you'll feel your needle go right into the cartilage. You'll have to withdraw it in order to be able to do that. We're doing pretty good now.
Excellent. Outstanding.
Yeah. So that's looking pretty good. I'll do it just a teeny little bit. I think she has too much of a super tip break here, so I'm going to give her just a little bit in there as well. And now we're going to start to have fun with the lower part of the nose. She has a little scar here. Is that a chickenpox mark?
That was a dermatologist.
A dermatologist, those evil people. What did they do?
Jeepers, creepers.
What did those evil people do? They took a little mole off?
When I was 15.
I'm going to see if I can elevate that little scar for you here just a bit. There's going to be some blanching because it's intradermal. But we're going to give it a little bit of a... Can I have a little bit of the ultrasound gel now, please? So I've used there, I loaded 0.2. I'm down to 0.07. So I've used 0.13. Thank you. Kent's going to start measuring the angles over here to see how we're doing. Again, when you do a midline structure, the best way to check on a nose, I want you to see something on our nose now. Look at the light reflex, and you can see that there's a curve to the light reflex over here. Do you see that? I can see it. It's not straight. And I want to look from above, and I'm not happy with the straightness over here, so we're going to adjust that over here. You take a gauze with a little bit of water. We do this in the operating room. You just wet it a little bit, and you run it down the nose like that. And then you see where the light bounces off, and that will tell you whether her nose is straight or not. It's looking better. Okay. Now we have the challenging part, which is this part over here. My oh my, she has a septum that's completely dislocated over here. Do you see that? Her septum is completely into her right nostril. And it's pretty tough. I don't know if I can push that septum over. I think even with surgery, it's completely off the vomerine groove, which is the groove that it runs in. It's off the nasal spine as well. So she needs some septal work that's done over here. In somebody who has a mobile septum, I'm able to push them over sometimes with a little bit of filler. Can I cheat on her? I don't think so, but we're going to try.
You might be able to lift the lateral nasal sill and the lobule and make it look a little better, but not the septum.
Oh, I'm going to go after a couple little things here. You're good?
Yeah.
Mm-hmm.
Great. Okay, let me have the same product in a needle over here. I want to see what we can do a little bit over here. This would normally be a surgical thing for me, but if I can... Which way do I want that to go? It's a little shifted this way. Let me try it from the other side. This is a challenge because that septum is way out of kilter. Mm-hmm. Okay, so I'm looking for the membranous part of the columella, which is this part, which is loose. Can you see, guys? Am I blocking you? No, you're okay. And you're going to feel a little stick as I let it fall in over here. And I'm going to start to put in a little bit of product that's sitting at the junction between the membranous columella and the actual anterior portion of the septum.
Sometimes if you just lift this a little bit too, at the same time.
Thank you.
Then it's the opposite of what you'd think. You're on the opposite side.
How you doing?
Mm-hmm. No, she never had so much fun.
Is that better?
Yeah. It is better.
Yeah, I'm trying to push the columella back a little bit like that. Let's see if we can get it to go just a little bit more. Good. You guys can see, you tell me. You all right? Mm-hmm. I'm putting in, and I've used the last 0.07. There we go. Okay. Next, let's try some other stuff on her. Give me some, what's the thinnest stuff we have? We have Resty Silk. You have the 50/50? Yes. Let me try a little bit of that. I want to show you some little tricks over here. Look at her from the side. Okay? We have a nice dorsum now. We have a little tip. We have the upturn of the angle. But this is too much show for me. And when she breathes in, it's going to collapse. So watch what we're going to do over here. We're going to hope this is working. You okay? Mm-hmm. You want a drink of water or something? You're doing fantastic. This is one of the more sensitive injections, but I'm going to try to do it as non-noxious as possible. Cleanser and a dry one. Thank you. Use the dry one. I'll take a cleanser. This is the lower lateral cartilage over here. You see the edge of it? And then there's skin-to-skin apposition between these two areas right here. Okay? This is skin to skin, and there's the edge of the lower lateral cartilage. This is an Ehlers shift. There's nothing I can do surgically to do this. Millard, the guy that I trained with when I was a resident in Florida, was amazing. He would do these surgeries where he'd move things around. I could never do it. So, I retract the nose. Ready? And I let it fall in to the needle. I start the flow of product. I'm below the leading edge of the lower lateral cartilage. I start to inject very slowly.
It's a little sensitive.
Oh, it's very sensitive, and she's being amazing. And then as I inject, I'm advancing my needle. I'm in between the leaves of the skin. Okay? Look how slow and you're going to see the skin blanch a bit. As you can see on my injection point over here, how the skin is blanching. Don't worry about that. I'll worry about it. You don't have to worry about it. Here we go. And another little injection right there. Very slow injection, very small amount of product. The skin will blanch.
So is this silk straight up?
This is silk, I think, with a 50-50 blend. Is that correct? And then you massage the area just a little bit. That blanching is because of pressure, and it's going to settle down. Better settle down. It will.
That'll be fine.
It'll be fine. Starting to settle already. Okay. Good. Now what we're going to do, because we inject the nose with lidocaine and epinephrine all the time. Okay? There, it's starting to settle already. Okay, but look at the difference now in the height of the nostrils. Okay? Look at this side. Look at this side. Okay? What I'm doing is I'm forcing that nostril down and giving her some... Okay, you see how this one's peaked up? And this one's down. Very typically, when you get a patient who's post-rhinoplasty, I'll hold this for you. You going to sneeze?
No, my eyes are watering.
Oh, of course they are. That was a tough injection. You okay?
Mm-hmm.
There's actually a reflex over here. You know that if you tug on the nasal hairs, you get your eyes to water. That's what they do out here in the industry. If they want to cry on demand for a movie, they turn their heads away from the camera, they pluck a nasal hair, and they start to cry. Meryl Streep has a bald nose. No, but I'm saying, but that's one of the tricks that these guys know to do if they want to get tears on demand. So, yeah, see, it's almost all gone now, the blanching. It's just a small little area over here that's left. Okay?
How long will that last now?
It lasts a really long time. A really long time, because there's not a lot of movement over
Unless
there.
you're a rabbit, you know, that type of thing. It's just...
What, 5 years? 3 years?
No. It lasts at least a year. Usually, he's being conservative. So a little conservative, and then you let the patient come back, and you might do a little bit more, and then I've had patients, this will last up to 2 years before you do a little maintenance on it. And the maintenance doesn't require much.
Everywhere there's a crease on the nose, there's a vessel underneath. That's what Roerich and Pessa have shown in their most recent article. You have a crease over here, there's the iliac artery. If you have a small crease that's sitting somewhere over here, then you have the lateral dorsal artery sitting underneath there. So you have to inject off of creases for the most part to stay away from trouble. She's collapsing over here. Okay? There's a little collapse of the nostril here, and there's also collapse at the internal valve, which is the junction between the upper and lower lateral cartilages. What I'm going to do is I'm going to try to inject in these areas, but I must be intradermal, which is a very tricky thing to do in a nose, because you saw when you're intradermal, she's almost gone with her blanching here. But you see that with intradermal, that you do get blanching because of the end arteries. It's like a pressure sore. So you're going to feel, could I have a cleanser again, please? I'm going to try to do this because she has complete collapse of her nose when she's breathing. We're going to fire in a little bit of stuff, like that. And I'm keeping my hands away so you can see. There's quite a bit of light reflex over there, so I don't know if you can see exactly. But I'm intradermal, and I'm putting in a small amount of Resti. This is Resti Pure, I think, or Resti. It is.
Silk.
Yeah. It's regular Resti. I want something that's a little stiff for that internal valve. And we're going to do it again over here. You're okay?
Mm-hmm.
Small amount. And I'm right over that lateral dorsal artery. I'm sure of it. Just gentle injections. And then she had some collapse up over here, so we're going to give her some support right there. It's even coming out of the pore there. I'll go nice and slow. Can I have a little bit of arnica gel or whatever we have? Breathe in for me. Still burn. Whoa, you strong. We're going to have to do a little more here. What I'm trying to do is stiffen that skin so that it won't collapse as much. I might use a little bit more at the bottom as well. Do you have that little retractor that you were talking about?
Yeah, right here.
Where do you get those?
Wants to know where you get these.
I heard him.
Yeah. They feel small.
They're made by a cosmetic company used for makeup around the eyes. I use the backside for rolling fillers around the orbits, and the flat side for for exactly this. And then you get your hands all out of the way. It's quite nice to use there.
My first time using it, and I like it.
Yeah. And I wasn't trying to be cute. I can't remember the name of the company. My nurses will know. My staff will know. Because we just got them to give us a whole bunch of those. We just clean them with alcohol, and they're very nice for noses.
Breathe in. Again.
Let's see. Now, can you breathe in one side better than the other now?
Still blocking a bit. Keep going. Let me see where it's buckling. Right here, down here. Yeah. Give me a little more of that resting.
It is better.
It's better for sure, but I want to give her that breathe right strip just by giving her a little
These are a little bit of a project.
Project is an understatement.
Would you consider injecting your technique that you taught me about the piriform fossa that go right across towards the lateral commissure?
Yes.
To lift up that base of the nose. Her
We're going to try
nasolabial fold is, the nasolabial angle is good.
Fighting.
But she's a little bit.
Yeah.
She's a little bit sunk right in here.
Breathe in again. Again. Oh, she's
better.
I think what part of the issue is, to be honest with you, I think when we do the opposite side, here we go. This is very delicate because the large pores, my product is coming out of the pores. I don't know how much in effect. Do that again. Oh, there's the break. I got it. You're not getting away from me now, girl.
How much product have you used so far?
He doesn't know.
About a cc and a half. I started with 0.2, which I used on the dorsum of the nose. I was left with about 0.4, and now they gave me this. How much was in here? 0.15? So I've used 0.4.
That's what I do. I ask my nurse, how much did I use? I have no idea.
0.14 and 0.07. So I've used a little bit more than 0.1 cc, more than 1/10 of a cc, just a tad bit more than 1/10 of a cc.
Would you consider doing this? I think I would.
Yeah, I'm going to do. Yep.
It might give us a little
support. So give me the purling.
So if we lift here, you guys, then it'll lift this up.
Yes.
Yeah, that's what I would do.
Yeah, we're going to do.
And if I'd do straight up.
What's that?
We had the Ultra Plus.
Yeah, that's good.
I'd straight up Ultra Plus or Voluma or Perlane.
I'll use it like this, but give me the red needle, please, if you have one.
Now watch what he does here, because this is a neat little trick. It's very safe because he's going to be right on top periosteum.
What am I doing? Does he know something that I don't know?
I hope somebody knows.
Somebody must know. Can I have a cleanser and a pad, please, again?
You're doing great. Good.
You're doing great.
Everything looks great.
You're a tough case, and I love challenges.
See, all she knows is you just stuck a bunch of needles in her. She has no idea what you're doing.
So what's my angle, guys? Is my angle this way?
Okay, pay attention.
Or is my angle this way? And what am I aiming for? Commissure on the other side. Retract the nose. 3, 2, 1.
Bingo. And right on top periosteum.
Okay. I got to make sure that I'm touching bone. I'm going to dull my needle to show you that I can't go any deeper. You must be touching bone. I'm going to put usually it's about a 0.2 cc. I'm going to put in about 0.1 to start off with. I'm actually looking at the monitor because I can't see my syringe, but that's okay. I'm not watching my syringe. I'm watching her nose. I'm going to do this. Now that I have a slight bolus, I'm going to gently release off the bone and lift.
And then what he's doing is lifting it up a little bit as he fills, and the filling creates a little bit of lift. He's lifting the base of the nose.
With my needle.
Right. And the filler, and then you lift it. The filler lifts as well. And now you're talking.
There we go. How you doing?
Good.
Good? I've stuck 28 needles in your nose. You shouldn't be doing good. I always like when patients say thank you at the end. I said, what are you saying thank you for? I was just sitting here torturing you for half an hour. Yeah, but I asked you to do it. That doesn't
I had a patient last week that cried and bellered the whole time, and at the end of the day, when she sent me flowers.
Breathe in.
Instead of the other way around.
Breathe in. Yeah.
There you go.
There you go. Better?
Mm-hmm.
Mm-hmm.
So that's what I was saying on my video there.
Your husband says you snore? What an evil man.
So this procedure, if you're a hurry-up type of doctor, it's not for you. This is a little fiddly. No, it's when my nurses say I'm
Never do. Just run late. That's
usually
what you do.
my nurses say you're an hour and a half behind. I usually say, tell somebody who cares.
Can I have a little bit?
No, we're not that bad.
No, the stuff that I was using.
No, you're right. You want more. You want more than
BD2.
15 minutes for this.
And a dry sponge, please. What we're trying to do is just create internal splints on the trick is, again, just so we understand, the trick is if her tip was down, we would have put in product onto the nasal spine to elevate the tip and to change the angle. Okay, number one. Number two is putting in product at the base over here, which I save for the end after I get some structure over here, but I mean, you can do it any which way you want. You put product on the bottom to give back the piriform support, putting product at the base of the sill in order to give it structure over there so that it has something to sit on, and then doing these intradermal injections. The intradermal injections, I told you, is the only time that I venture away from putting stuff on bone in the midline is to treat these internal and external nasal valves. So we have to sort of figure out a way to do the same thing on the other side. I'm going to go for the internal valve first. Can I have a sponge, please? And we're going to do a little bit of this. Again, make sure my hand's out of the way. We're going to turn her head a bit to the side. We're going to pull across. Here we go. Pull across and fire it in. Okay. And then very slowly inject, watching the skin.
Now, she's an amazing patient because
She really is.
She's got good discipline.
Hurts. This kills. And she's being amazing.
Motivated.
You're motivated. But really, if you were to talk about 10 being so painful that you want to punch Kent, because it's his fault, and 0 being no pain, where does it fall? About a 4 or 5?
Probably
5. Yeah. Noses are like that. Everywhere else, it's probably a 1 to 2. I'm keeping my hands out of the way so you guys can see. Normally, I've been having my finger over there to retract the nose a little bit.
So the advantage of these minis is you got a 31 gauge needle. The rheology of the syringe and needle is such that you have perfect control. You can feel what you're injecting because it's the proprioception of it is enhanced. We tried to use these in a country we were in recently, but they wouldn't let us use these minis.
That's right. And I think when you use them around when you reconfigure the product, she has larger pores here. You can see the stuff coming out of the pore. When you're switching to a small thing like this around the eyes or in the nose, you're actually increasing your safety margin. So I think it's something that the companies should eventually try to convince us to be able to talk about. We have to convince them, I should say.
But you're also increasing pressure. So you have to slow down.
That's right over the alar artery right there. She has a little bit, I know she's going to collapse a bit down over here. That's probably...
Got more product there.
Yeah.
You're going to need some more. What do you want, Arthur?
Same thing. Yeah. Give me the Resty Silk. I'm going to use it.
Yeah.
Well, give me the Resty Silk. I'm going to use a little bit down over here. That's the killer.
So you're mixing products here a little bit. On one side of the nose, is there a problem with using different...
No, I use silk over here. I'm going to use the same thing over here.
Yeah. So there's not really a problem with using... We use different products. Same zones.
You okay? Mm-hmm. Small injection. Very slow.
Might try my little retractor there.
Yep. I'm going to do that on the base. I'm going to need some of the Resty Pure for the base over here. I'm good.
She wants to blanch, doesn't she?
She is. But she's had surgery here too before.
Yeah.
You know, I'll tell you a story that I told you I didn't have a vascular accident in my practice yet. Like I keep on knocking on things when I say that. But I had a patient that came in to see me that wanted her nose done. She said, I hear you do these things with noses. I said, sure. She says, I've had a rhinoplasty. I said, I could see that you have. It was a little bit scooped out and everything. And she had this broad, flat tip. And she said, I don't want to go through another surgery. I said, okay, well, tell me when your surgeries were. And she said, I only had one, and it was back 10 years ago or 7 years ago. So I said, okay. So I went ahead and planned out my injections. I injected her the way I thought I was, staying in midline, turned around to get my ultrasound gel, turned back, and her whole nose was purple. The entire nose. I don't mean just a little bit of it. I mean the whole wedge of the nose was purple like this. There's no feeling in the world when your alimentary canal shrinks to about 1 inch. When it feels like your anus is up at your mouth because it puckers so far up. There's no feeling like that. I looked at her.
A little more dramatic.
Yeah. I looked at her and I couldn't understand it. And I'm saying in my head, I know I stayed in the safe area. How did that happen? I'm thinking to myself, and I looked at her and I said,
how many rhinoplasties have you had?
How many rhinoplasties have you had? And she looked at me and she went, 7?
Exactly.
Once they have surgery or repeated surgeries, all bets are off because you're destroying the natural architecture of the nose and the circulation, and what's left behind is perhaps one vessel supplying the whole nose. And in that situation, it's very possible that I caused external compression that was causing the problem because there's only that single vessel. There's no friends that are helping it. The problem is when you see a purple nose, it could be venous, it could be arterial. I didn't have a chance to see it because I had my back turned, took the ultrasound gel. When I came back, she'd already turned purple. I missed the possibility of her blanching. If she blanched, I would have said, okay, then it must be arterial. But I never saw that. So now I don't know whether it's arterial or venous.
Make it bleed.
Yeah, and then you're stuck with a problem. Because the problem is your treatment is different. Hyaluronidase is still the treatment of choice. But I want to make sure that she gets circulation back. If it's a venous occlusion, that means that the sink is closed and there's more fluid coming in. I have to give her ice to slow down the arterial supply into the nose so she doesn't congest. If it's an arterial occlusion, I have to give her warm compresses to open up the artery to get the flow in. But I didn't know which one it was. What do? You don't think straight at those days, but what do you do in those times? I did just what you see me doing right over here right now. I pushed my finger on the nose and I released. Look at her refill over here. You can tell she's a previous rhinoplasty patient. If you see rapid refill, that means the artery's open and it's flooding back in. If you see slow refill, it means the artery's closed and it's having trouble with blood getting back in. If you see rapid refill because the blood's coming in, then you have to give ice. If you see slow refill because the blood's having trouble getting out, then you have to give... Excuse me, that's the way you give ice. The other one you're giving warmth, right?
Yeah.
Excuse me, that's the other way around.
Right.
In actuality, she was a venous occlusion, not an arterial. She came back, refill came back right away. I saw right away that she had rapid refill that was arterial. So the blood was coming in, it was having trouble getting out. It was actually a venous occlusion. So I gave her ice to slow down the blood coming in and gave her hyaluronidase and she did fine. But always go with the capillary refill. That will tell you what's happening. Everywhere.
Not the whole nose.
I coated it everywhere. I couldn't do it with a cannula because she was scarred. So I ended up doing it with a needle. And then you run the risk of having a bruise over there. But she perked up. It was a purplish pink, She perked up quite a bit. You're okay? Mm-hmm. Let's see how you're breathing. Breathe in.
Oh, yeah, much better.
See? Do that again. Come on. Force it. Let me see if you can get that stuff to collapse. There you go. You're really working hard. Which one's collapsing? No, they're both collapsing because we forced you to do it.
Right,
but that's pretty damn good. You feel that you're breathing better? Mm-hmm. You don't usually take in big breaths like that when you're sleeping, I hope. So I don't think you're going to snore. If that's the snoring situation, we're going to be pretty good. But look at the amount of nostril show that she has now on the side of the nose. She was up before like this. I still have to do a little bit of bracing down here at the bottom. So I have, what's this that you gave me? That's it straight? No, it's silk. This was silk? Yeah. I don't say I don't want it, but I'm not going to use it. Where's that little retractor that you had for me, Kent? I'm going to get used to that little thing. Wow. So what Kent gave me this a while back, it was when doing tear troughs, so you can sort of roll the product into the medial tear trough. But now the smart boy is using both ends of it. That's a very cool thing to do. So let's take some questions. I got to do her temple on the other side, and then we'll maybe get to another patient.
There was something you wanted me to ask you about the tear troughs and how everybody.
What did you want? What did you ask me about?
Always go back with the cannula.
Oh yeah. Okay. So here's the story. I'm going to go down in there. This is the tough one.
So maybe explain what you're doing there. He's on the nasal sill, and he's lifting up the nasal sill towards the lateral side there as well. So.
Nice slow injection. I'm going to come down a little bit over here. A lot of these things that are discovered, like when I found that I was able to straighten noses was because when I was putting local anesthetic in on patients that I was going to operate on, I saw the nose start to shift just with the local anesthetic. You can scoop out whatever extra stuff there's in there as well. That's really great. That's great. Breathe in and out. Nice and slow. Breathe in again. That's the breath that you're just going to take. Beautiful. Again.
And you do the piriform fossa.
Yeah. I'm going to use the rest. Give me the Perlane and I'll do the piriform fossa on that side. You're doing great. You're doing great. No, I'm not doing anything. You're doing it all. Sometimes it works well, and sometimes it just sort of... Ultra Plus. You can see a lot of swelling in lips with Resty Silk. Resty Silk is a lady. You got to treat her well. If you smash her around a little bit, or if you bang her around a little bit, she'll get mad at you. She's a princess. Yes. And we've had it as Restylane fine lines for 18 years now. So, if you get the angioedema type of thing, steroids is the only treatment. And or nothing, because it'll settle in about 24 to 48 hours. 48 hours without steroids, but if you want to give them a quick pulse, usually it's 30 milligrams of prednisone, one shot, and then they'll deflate right away, because there's an angioedematous thing that happens. It's probably related to the CD44 receptor on mast cells. That's what we think. But that's where you inject a patient within 10 or 15 minutes, where they call you 4 or 5 hours later, and they have this massive edema of their lip. It's not the hygroscopic effect of the product. It's not the fact that it's drawing in so much water. It's causing leaky blood vessels that are effluent. It's stuff that's coming out. So the prednisone will help on that. One dose, it settles down, and they get a beautiful result afterwards, but they really go through a day of looking very unusual. It's unusual. The thing that you do, and you heard Ken talk about it, and he'll talk to it right now, is do you mold, blend? What do you do when you use...
Blend, mold, and massage. Blend is gentle. Gentle is like treating a doll.
That's right. It's a princess. We're used to pumping stuff into the lip and then trying to mold it and shape the lip. You can't do that with Resty Silk. You got to really be gentle, and the product belongs between mucosa and muscle and not in muscle.
Not in muscle. It doesn't like muscle.
Doesn't like muscle at all.
Do you blend it for the lip?
Yes.
So do I. Can I have a cleanser, please? I was waiting to hear doing the same thing that I'm doing.
It varies a little bit, but anywhere from 1 1/4 to 1 1/2.
Small stick.
And see, this is one of the neatest little techniques right here, to lift that base of the nose, because it's an aging, deflation, retrusion. This area retrudes, just like mid-face retrudes. It's essentially part of the mid-face retrusion. And you're creating a little projection that goes anterior and superior. It lifts up the whole base of the nose.
There we go.
And if we were in a clinic environment, we would have showed her in a mirror and had her look with her brain camera, that she could see all the areas before we started. But it's a little difficult environment here, but that's how we usually do it. And then she'll be able to, but I think she's got a pretty good eye. She'll be able to see it.
I'll take a little bit of the product for her temple on this side, and we're done.
And because all she knows is Arthur just stuck a bunch of needles in her nose here, you have to sort of after explain and show her in the mirror what's been done, where it's been injected, the root of the nose, the radix, dorsum of the nose, all those things that he did, and then it started to make more sense. In my experience, I'm sure you have the same, and when you inject patients like this, there's 3 types of patients when you show them in the mirror. There's the light switch. They can see it immediately. There's the dimmer switch that it takes them a few minutes to kind of look at it. And then there's the sunrise. Those that get home and phone the next day and say, oh, fantastic, I can see it. So the light switches are better because they're more visual. But most of my patients are sort of dimmer switches that takes them a few minutes to kind of see it.
Do you ever have any trouble with the temples post-facelift, brow lift? And if so, what do you recommend?
You have to be careful in previous surgical areas, like I was saying before. Again, there's no bleeding here, but I'm going to take the pad that we were using to stop the bleeding around here, where I went through a little vessel over there, but nothing much is happening now. Gentle breathe in. Go ahead. There.
So what kind of brow lift are you talking about? Right above the eyebrow or in the traditional forehead lift?
When I'm filling temples, usually with microcannula, it's scary, first of all, because I think that the vessels are held in a vice, and I'm nervous
You can.
I typically go and do this technique with a needle. So my question is really, with this needle, do you ever have any trouble post-facelift with all the scar tissue?
No, I mean, we don't usually go down on that plane in the first place when we're doing brow lifts or we're doing temple tightenings and things like that. We're usually above that area. There's no reason to elevate the temporalis muscle. It's really stuck down to bone. Even if when you go ahead and do any type of anatomical dissections in the lab, it's hard to lift that temporalis muscle up. It's really anchored underneath there. So it's a safe place to go ahead and inject, even in patients. You know, once you operate on somebody, like I said, all bets are off because the anatomy has changed. But the interesting thing about the face is the fact that vessels can go hither, tither, whatever you want to call it, left and right, up and down. They go all wherever they want to. There's so many variations. But the one thing they're fairly consistent in is the depth at which they run. So by operating on something, you're not going to end up putting a vessel down on the bone. So if you stay in that safe area, you'll be okay. Going in with the cannula, as you said, is a little bit more precarious in a fixed bed because you can enter into a vessel with that. Make sure that you're going perpendicular to the vessel direction if you're going to do that. But I think it might be safer to do it with the needle. Okay?
It flows just as well down into the deep end of the swimming pool.
Right. It'll flow everywhere. Actually, what it does is when we dissect out what happened, I thought originally I was injecting under the muscle. I don't know why I thought that. So we dissected it out when I was in Australia, and we found that the product was intramuscular, and then it runs between the fascia and the muscle. The product will take the place of least resistance. So it wants to stand up. If you inject high up over here, the temporalis muscle is extremely thin. If you start to inject further on down, more than a centimeter or two, the muscle gets too thick, the product can't get to the surface. But here you see it come right up between the fibers. It hits its head on the ceiling, which is the deep temporal fascia on the surface of the temporalis muscle, and starts to spread in the plane between deep temporal fascia and muscle, which is exactly what you target if you're trying to go in with a cannula. So I'm allowing the product to find its happy place without me actually directing it there. That's the cool part about it that I really like about this technique. And so far, it's been very consistent and reliable and reproducible. And the product will last forever. Product on bone, there's less hyaluronidase there for the actual body to eat it up. There's glide planes. There's nothing really moving over there. When she chews, really, it's not a whole bunch of movement like it is on a facial muscle that's moving quite a bit of excursion. So there's very little shear force. You have your hand up because we have to take a break?
Now,
oh, there's a question.
You could get really cute here and draw and create this. The brow tip is a curvy linear line that he's now got back to where it's more, your eye likes it better. And this dorsal aesthetic line is now more parallel with her nose all the way down. Because it was kind of wonky all the way down here. Now he's got this, and that's a medical word, by the way.
Wonky, yeah?
Yeah, wonky. So now it's much straighter and more, your eye likes it better, and she'll have this reflected light that Arthur was talking about there. So she's got that curvy linear line, that brow tip is the curvy linear line you want to get back, and then the dorsal aesthetic line, if any of the facial plastics are here, that's what they talk about.
Breathe it.
So much, much better.
So she's breathing a lot better right now.
Oh, yeah. Can you feel it here?
Yeah. Now, a little bit of blanching and then stuff that's over here that you're saying, does he realize that she's blanching?
Wipe off all that.
That will settle down. But every nasal injection that I do in my office does not leave my office for 15 minutes. They have to be back to their normal color within 15, 20 minutes. She had, in this area, she had actually rusty silk that was blended 1-to-1, but has a little bit of epinephrine in there. And that little bit of epinephrine is, I believe, is what's causing that little bit of blanching. I'm quite sure there's not a lot of tension or pressure over here at all. We can clean all that off. And it's much smaller than it was before. I'll give her 15, 20 minutes. We'll put a little bit of warm if we want on there, and she'll be fine. It should be perfectly fine. There's a question back there. Let me just take the question back there, or Kent can take it.
Can you use Sculptra using the same technique that you just described for filler in the temple?
Can you use Sculptra? You can, and I think you should still put it down onto bone using the same technique.
Wow. You're missing your wow.
Missing the wow?
Which is a light switch.
It's the same word in every language, no matter what continent you're on. If they always say, even Chinese, Italians, they'll all go and they go, wow. That's the thing. It's the only word that I can say in all languages. Yeah, you can put Sculptra over there. Becky does it. She does it beautifully. Danny Vlahar was in my office about 7 years ago to show me how to use Sculptra, 7 or 8 years ago. And they're putting it on piriform. Originally, Sculptra was used in a lot of sort of fanning techniques into the subcutaneous area. And the idea was, to do 5 treatments and to bring the patient back every month and stuff. But interestingly enough, when stuff is designed for a certain area, sometimes they find out that it performs even better in another area. And if you put it down on periosteum, it's actually quite stimulatory for the periosteum as well. So that's fine. Yeah, you can do it that way, but always keep your eyes on the patient when you're injecting. Sculptra, the only issue is going to be is the fact that depending on how you reconstitute it, we used to use it when it was Neufil. Neufil was a 3-to-1 or a 5-to-1 reconstitution. You put 3 or 5 cc's in. It was too thick. We had to put it in through 21 gauge needles, or the 20 or the 26 or the 27s would clog. But if I was to use Sculptra in a temple, I would probably use it as either a 10, 12, or even a 20 recon. And I would use a needle that's probably at the most a 25. So it's a little bit of a bigger needle. Expect you might get a little bit of a bigger bruise. That's all. I'm sorry? I would use the same technique. Yeah, I would use the same technique. She's a great patient. She deserves that. You're good?
Thank you. Can
You're
I
very
give
welcome.
you a hug?
You can give me a hug. No problem. Thank you.
See, all she knows, all these fillers now have an anesthetic. Remember the days they had no anesthetic in them? So now the bad thing about them is they have an anesthetic in it, so it makes her feel like she's got this great, huge nose.